Greetings. I'm Dr. Deborah Fennell, and it's my pleasure to welcome you to the International Nurses Society on Addictions webinar series that focuses on the use of opioid therapies for treatment of opioid dependence and on the safe use of opioids in treatment of chronic pain. This series is one of many resources made available to the prescriber's clinical support system, Opioid Therapies, a program that is funded by the Federal Center for Substance Abuse Treatment and operated collaboratively by 6 other partner organizations: the American Academy of Addiction Psychiatry, the American Psychiatric Association, the American Medical Association, American Osteopathic Academy of Addiction Medicine, American Dental Association, and the American Society for Pain Management Nursing. I'd like to just go over a few quick housekeeping notes before we get to today's presentation. In the upper right side of your computer screen, you will see a control panel. In the lower portion of that panel, participants can type in a question or comment and submit it to the webinar organizers. You can do this at any time during the presentation. We will reserve about 10 minutes at the end of the presentation for questions and answers. If we're unable to get to all your questions in the allotted time, I will respond to them in writing. The webinar, presentation slides, and questions and answers will be posted on the PCSSO website in the near future. Today I will discuss the sudden closure of a buprenorphine office. Are you prepared? I hope to increase your awareness about the need for an emergency plan in the event the office is closed and patients are unable to access treatment. I will discuss planning tasks to guide preparedness for the physician and the team providing office-based treatment, as well as anticipatory planning for patients. Just to introduce myself, I joined the faculty at the School of Nursing, Johns Hopkins University in January. I'm a board-certified psychiatric mental health nurse practitioner and board-certified addictions registered nurse at the advanced practice level. I'm a fellow in the American Academy of Nursing. I am immediate past president of the International Nurses Society on Addictions, and I'm the project director for this webinar series. So without any further ado, let me just start today's presentation. So here's the objectives that I briefly described in my introduction: to consider the impact on patients of the sudden closing of an office-based buprenorphine clinic, to emphasize the importance of planning for emergencies, and analyze planning tasks for preparedness for unexpected closure of an office or clinic. So let me start with some of the background. This presentation was prompted by an event in August of 2012 when patients came to their physician's office for the Suboxone clinic and found it was closed. The physician had been arrested following a DEA investigation, in part for unlawful issuance of prescriptions for controlled substances. So the local news picked up the story on this office closing. These are some of the responses from a patient and comments and recommendations from the reporter. So patients said in the report, do they want everybody to turn back to drugs? I don't know what to do from here. And then the reporter commented, with the office now closed, they have no access to care, and many, including those who turned up for the Suboxone clinic, are panicking. And then the recommendation was, if you're looking for a referral to a new doctor, crisis service can assist you. Well, in that same report, there were also some comments and some insights into how patients were impacted. I drive 2 hours to come here, 2 hours one way. So I do 4 hours every Saturday, once a month, and he was the only doctor after spending 6 months locating. This is the only doctor I could get into. I don't know where to go anymore, and I know there's a lot of people who are in the same situation I am. I don't know. I've called other doctors. And finally, There's a note on the door saying to go to the ER. The ERs do not treat people on Suboxone, nor do they have Suboxone. Hopefully, those of you who are attending today are familiar with the clinical guidelines for the use of buprenorphine in the treatment of opioid addiction. This is Table 6.1, or Figure 6.1 from that guideline. And this figure summarizes policies, procedures, and items that should be established or arranged for in a medical practice prior to initiating office-based opioid addiction treatment. A primary focus is on ensuring the highest quality experience for patients, providers, and staff. As such, it's important to establish comprehensive networks for high-quality, safe, private, and confidential treatment. The items that are in bold font will be emphasized in this presentation. Office closings precipitated by arrest of a physician should be rare events. However, there are lessons to be learned from environmental disasters such as Hurricane Katrina. The following is from John Bowen's report in the 2005 SAMHSA News after Katrina. And I quote, "In the wake of Hurricane Katrina, patients in opioid treatment programs, or OTPS, in the Gulf Coast region found themselves cut off from access to their daily medications, specifically methadone and buprenorphine. All 7 OTPs in the New Orleans area were shut down by the storms. Prior to shutting down, all OTPs were able to implement their disaster plans, which included providing all patients with a week's take-home supply of medication. Across Louisiana, 6 OTPs were still open. They prepared to receive any opioid-dependent patient who might need services. To make matters worse, more than 5,000 physicians had to evacuate the New Orleans area. Of these physicians, approximately 34 were registered with SAMHSA to provide buprenorphine. In addition to an unknown number of medical practices that had been engaged in management treatment, pain management treatment with opioid therapies, meant leaving those patients without providers to continue their treatments. As a result, in the days that followed the hurricane evacuations, patients were walking into clinics in Baton Rouge, Houston, and other cities desperate for their medication. In many cases, they had no proper identification papers, no medical history in hand, and no proof of participation in a methadone or buprenorphine program in their home state. And that ends the Bowen report. So one of the questions that I had is, how did people fare in Hurricane Sandy? There aren't data to inform us of the impact except some anecdotal reports. Perhaps some of you attending this webinar have firsthand experiences from those regions that have been impacted. If you want to share your experiences, please put them in the questions section of the webinar feature. Time permitting, we'll read them, and we'll certainly include them in the archives of this webinar. Additionally, despite the best laid plans for vacation travel, events occur outside our control that cause delays. Remember how air travel was disrupted in the days after the eruption of the Iceland volcano, and more recently the cruise that was stranded for 5 days? Whether a natural disaster, travel delay, sudden or prolonged illness, physicians and patients need to plan accordingly, as well as other treatment providers in providing this essential treatment. Office treatment programs are required to have a disaster plan. Opioid treatment programs are required to have a disaster plan, but no such mandate is in place for office-based buprenorphine treatment. The clinical guidelines for the use of buprenorphine in the treatment of opioid addiction do state that, quote, physicians should arrange for other physicians with DATA 2000 waivers to be available to provide care to the treating physician's opioid addiction addiction patients in the treating physician's abstinence, and I add, while on vacation. So returning back to the story that sparked this topic, who was involved when the Suboxone clinic was closed? Well, because it was a DEA investigation, DEA was the first to be aware. Local law enforcement were involved in making the arrest. Patients were likely the next to be aware when they came to the scheduled clinic and found the sign on the door directing them to the emergency room. Local media picked up the story, relaying, quote, if you need immediate medical attention or if you are in need of a prescription, you need to visit an urgent care facility or an emergency room. However, if you are looking for a referral to a new doctor, crisis service can assist you, unquote. The State Opioid Treatment Authority, or SOTA, is responsible for providing administrative, medical, and pharmaceutical oversight to certified opioid treatment programs, including but not limited to planning, developing, educating, and implementing policies and procedures to ensure the opioid addiction treatment is provided at an optimal level. If the DEA is involved in closing a clinic, the State Opioid Treatment Authority and/or the Substance Abuse and Mental Health Services Administration would be contacted. However, the SOTA does not have jurisdiction over private office-based buprenorphine clinics, so they would not necessarily be informed in situations such as the one that was described here. The respective region's SAMHSA Public Health Advisor would assist patients or their representative in linkage to a qualified buprenorphine provider. And of course, the SAMHSA Physician and Treatment Locator is a resource for patients and providers. Those of you attending this webinar may be knowledgeable about this resource, but are other healthcare providers, patients, or the lay public aware? You have an opportunity to share what you know with your colleagues in the emergency department, police department, local news media, and other audiences that may experience the ripple effect of a sudden office closing. So clearly we want to do all we can to support patient treatment and recovery. This requires proactive planning on the part of the patient and the provider. The remainder of this program was informed by materials related to healthcare preparedness from the Center for Disease Control's Office of Public Health Preparedness and Response. The information provided may be useful for office-based providers and programs in preparedness for unexpected closure. The plan includes tasks for office staff, providers, and encourages engagement of patients in proactive planning for their treatment and recovery when they are unable to access the clinic. So from the public health preparedness and response plan out of CDC, I selected the relevant planning tasks as I saw it that should be in place for preparing for closure. So each of these planning tasks will be reviewed in further detail. So the chain of command. Identify your office's day-to-day operations manager. Who will serve in the point role in the event of an emergency? Identify lines of succession and delegation of authority in the event of high absenteeism. Or you may be the sole provider in the practice. What do you need to have in place if you're suddenly taken ill, have an accident, delayed because of weather or other event? Identify a list of physicians available to provide care in the treating physician's absence. Be familiar with qualified physicians in your region and get to know them. It is important to ensure that staff are trained in and familiar with the emergency coverage plan, and be sure it's written, reviewed, and updated regularly. Communication. It's important to assign responsibility for communicating changes in operating hours and services in the event of an emergency. Also, to have developed processes for communicating, including a message that may go on the telephone, notification of answering service, signage for the clinic or office door, and so forth. It's important in terms of community integration to think beyond your office or clinic. So establish relationships with local pharmacies that serve your patient base. Update and maintain contact information for regional hospitals, including emergency departments. Maintain an updated list of physicians, again going back to the SAMHSA locator. Familiarize yourself with the community emergency response agencies. Through this, it's important to have continuity of operations. Identify your office or your clinic's essential business functions and determine how they will be maintained in the absence of the treating physician. Clearly, education and training are critical. It's important to share the written plan on emergency coverage with staff members and ensure that staff are aware of the chain of command for emergency closure, and to create opportunities for staff to meet physicians who may cover for the treating physician. So through this, doing proactive planning and anticipatory guidance. Some of the questions to ask in assessing gaps and vulnerabilities are, what does your office have or not have in place to ensure patients will receive treatment? What networks do you already have with physicians who could cover for you? Could you develop networks with other physicians that would ensure you do not exceed the number of patients the physician is authorized to treat? What is the depth and breadth of your support staff? So, establishing objectives to ensure continuing to see patients in an emergency is critically important, and part of that is to identify and evaluate your office's strengths, weaknesses, opportunities, and threats. In looking at staff-related considerations, maintaining current contact information for all staff. So do you have a roster that has phone numbers for staff home phone numbers and also cell numbers? To assign responsibility for periodic review of emergency procedures. So these procedures, if once developed, need to be periodically reviewed to make sure that they're current and to update any information for the emergency preparedness plan. Assigning someone who is responsible for that review helps to ensure that that will be completed. And ensure the office's day-to-day operations manager is fully aware of provider coverage and communicates the plan to staff. So let me turn now to patient-related considerations. We can engage patients from the beginning of care in planning and problem solving. We can provide materials for them related to office contacts, self-monitoring medication taking and supply, important contacts including the SAMHSA treatment locator, and their own readiness for an emergency. And finally, to engage in problem solving to anticipate and prevent crisis. So a form such as the one shown here could be used for multiple purposes. It could be used to orient the patient to the team. So think about all of the different roles and staff with whom the patient will have contact to help them understand the various roles and specific functions of the team members. Additionally, this can be used to provide education about who to contact and under what circumstances during and outside of office hours. Patients should be encouraged to keep a record of their medication taking, regardless of the type of medication, prescribed medication that they're on. Using a simple block calendar for documentation helps patients keep track of whether or not they take their medication. Patients can also be asked to make notes about any effects and side effects they experience on this calendar, and then bring the calendar to their appointment. As such, this becomes a tool for patients to self-monitor and keep track of their inventory. It also serves as a base for discussing their response to treatment with the entire treatment team. So important contacts is another essential tool that can be provided to patients. So this template could be provided to patients for their use and could also serve as a vehicle for patient education. For example, the importance of using a single pharmacy can be reinforced. This tool can also be used to reinforce the value of having medical, mental health, substance abuse treatment, and other treatment providers for their comprehensive treatment. Education can be provided on the appropriate use of the emergency room, and that the emergency room is not an option to obtain buprenorphine. The importance of a sponsor and other support persons can also be highlighted. This contact form can also introduce patients to the SAMHSA treatment locator and ensure that they have that website address. This checklist could be useful in the event of an emergency. Thinking back to the article in the SAMHSA 2005 following Hurricane Katrina, where people did not have ID or evidence of taking medication, this would help patients to know what they should carry with them, anticipating any obstacles to treatment that may be in their way. So having a valid picture ID, providing and having evidence of the proof that they're receiving services, such as the physician's business card with the address and contact information and a recent prescription bottle. Having a list of physicians qualified to provide buprenorphine treatment and a list of opioid treatment programs. So here are some questions that could be used to engage patients in anticipatory planning. By engaging with them in proactive problem solving, you are empowering patients to be more effective managers of their health. So some questions that could be posed in discussions with the treatment team is, what would you do if your medication supply ran out before your next scheduled appointment? What would you do if you were not able to get to the office for your appointment? What would you do if you were hospitalized? What would you do if you came for your appointment and the office was closed? Resources for office-based staff, I'm sure these are not foreign to you, but are listed here so that you do have the TIP 40 and the TAP 30. Now I'm hoping that there's some questions or some anecdotal stories that people want to provide related to this topic. What I would hope is that this inspires office-based providers to initiate or enhance their emergency preparedness plans. And so we'll open it up to any questions that people may have, or comments or sharing of experiences. So I'm looking at some of the questions that or comments that have come in. So one of the questions is, perhaps I'm not up to date. However, I thought that moderation management mutual support allowed for moderation of use of the primary substance of addiction, in this case opioids, to which the patient's addicted. For example, OxyContin. That would not be the milieu to which I would want to refer the patient. So I'm not sure if I'm understanding this. In terms of if you were looking at referring a patient because of the office being closed, I think the point is that you would want to refer the patient to a treatment provider that is philosophically aligned with the premise of buprenorphine and Suboxone treatment. If that isn't clear, then come back in with another question to help me clarify. Another point that was raised is that other circumstances of closure would be a physician moving or retiring, though those physicians would generally prepare the patients with a transitional plan, assuming there are other adequate prescribers in the area. Yeah, that's a great point. I think that physicians who are retiring or moving likely are going through a process of closing or shifting over their care of their patient population to another provider. But that good point that could be another reason for closure. Most in our area are at their limit for how many they can treat. Can someone who currently has 100 patients enrolled provide coverage and prescription renewal for another provider? I believe that the answer to that is no. And there is a process for physicians to have increased the number of patients that they can serve under an emergency. I would refer to that question directly to SAMHSA because they would be the ones that would have to be involved with authorizing an increase in the number of patients enrolled or making adjustments under emergency situations. Another question, what office records will be needed to submit to DEA for closing the office? That is a question that I am going to have to send to my colleagues at SAMHSA, and may even be a good question, unless somebody knows, that for another webinar in terms of what to do in relation to DEA. Can the state's prescription monitoring program be used to identify if a patient was taking buprenorphine? Another question that I'm not sure of, I can do some homework on that and then post that one on the archives as well. How do you assist a patient whose physician no longer accepts their form of insurance, for example, Medicaid? That is, so I'm presuming that you're looking at the patient with taking buprenorphine. And I think the way to do that is to look at the treatment locator and see what physicians are, qualified physicians are in the region, and then make contact with those providers to see if, in fact, they do take certain forms of insurance. It is going to require some detective work on your part as the patient advocate. Should the provider write a 1-week prescription for Suboxone for each patient? I think that the amount of Suboxone that's prescribed is really up to the prescribing physician and how and their relationship with the patient and the trajectory of the course of the patient. So I think that really is, there isn't a hard and fast rule to that. It really is very dependent on the physician and the course of treatment and the response to treatment with the individual patient. Okay, we have a response about the going over the number of patients, that there is not an exception to go over the limit of 100 even in an emergency, and we have an expert out there who works in this area and says we've come up against this on many occasions and there's no exception. And then back to the question about moderation management in general, was a question in general, not just relation to office closure. I understand the philosophy that that one could continue with OxyContin in moderation, certainly not commensurate with what I find appropriate abstinence to OxyContin in such a case. So I think the point here is that this is really a philosophical debate and oftentimes a clash between moderation and abstinence-based or harm reduction philosophy as well. So that's a much larger issue. I agree with you in terms of that question. So a response on whether a patient is taking buprenorphine, and so the identification of buprenorphine does come up with the PMP, so that it can be identified what patients are taking buprenorphine, and we have a confirmation on that from Massachusetts and Minnesota. And then a comment about I would encourage people to talk with your state authority for support and resources around a closure, as they can assist in mobilizing resources and facilitating treatment. Closure programs is more common than one would expect, and developing a strong plan on the state level can really assist. So I think that comment really speaks to the importance of proactive planning, making those connections in your community with your state authorities, and so that you're really working in collaboration with them to do proactive planning. Great question. Do you know when NPs will be allowed to prescribe Suboxone under a waiver? That is not going to happen until the Data 2000 legislation is changed. So right now the restriction is that physicians only can prescribe Suboxone or buprenorphine, and if you haven't seen the position paper that is posted on the INSA website, you should take a look at that. That paper was also published in the Journal of Addictions Nursing, and Stephen Strobe is the lead author on that paper. And so the INSA has utilized that position paper in really lobbying and educating our representatives about the importance of and the value that nurse practitioners could add in increasing access to this treatment if Data 2000 were made that allowance. So thanks for that point. So a comment from the VA Long Beach. We've been trying to integrate buprenorphine services. Recently, other psychiatrists agreed to take the buprenorphine course. The plan in the future will be moving to other departments such as primary care. Our VA moved from 1 prescriber to 8 in the past year. Wow. That's terrific. In the past, we used to have 32 patients, and now we have 92. We had to be proactive to convince the administration to implement changes, including attitudes from others toward this treatment. That's a great testimony to advocacy for increasing access to this treatment. So great shout out to VA Long Beach. Another comment about there may be an exception to the patient limit. Contact the Center for Substance Abuse Treatment to find out exceptions. In most cases, this has been relevant to extremely rural areas. You know, so good point, I think, to go right to the source for the information, and also looking at the treatment, the SAMHSA treatment locator, to identify where there's some real gaps, and it's in those rural areas. I think those are they pop out really clearly from the map, but also in terms of areas where the density, the prevalence of opioid addiction may be higher, and there may be a number of providers, but not enough providers to really manage the demand for treatment. Another excellent point here in terms of the PMP won't tell you if buprenorphine is being used for pain control or for opioid dependence. So that's really a key point too. That and again, that going back to Hurricane Katrina, where providers who were providing office-based buprenorphine treatment were dislocated because of that, but also providers who were providing for pain control also created some challenges for those patients. And I think another point in terms of the way for planning for a closure, and it sounds like particularly in rural areas where it's a distance for patients to get to an alternate treatment provider. And I think that was evident in the case that I presented, where one of the people who was impacted was talking about driving 2 hours to come to the clinic. And we know that there's other areas where patients have to drive many more miles and much more time to get to the treatment providers. When a question about the website, where the position paper is, we will post that website on the frequently or the questions that we post for this webinar. So we'll make sure that that website is posted so that people can access the position paper regarding nurse practitioners, qualified nurse practitioners, in opening up the legislation for Data 2000. And another another comment about the cap of where programs have closed with patients not being able to access other treatment providers, and where there was no exception to increase the cap for those patients requiring treatment. So no allowance for increasing the cap beyond that 100. So you'll see that the position paper information, the website has been posted for you. It's I'll read it just so that people listening to this website also have it. It's the http://www.insa.org/documents/INSA buprenorphine fact sheet, one word, .pdf. And we'll also make sure that we post the citation of the Journal of Addictions Nursing so that you can access that from the official journal of INSA. Another question that's come in is, in an emergency situation, is telemedicine to waivered physicians in other areas of the state an acceptable option? Great question, and I'm wondering if some of the experts out there who have familiarity with this, with telemedicine, if anybody can answer that, or it may be one that I will also direct to SAMHSA CSAT. In our state, this is another question that's come in. In our state, we have a law that says if a practitioner ceases to practice for any reason, a pharmacist may dispense all remaining refills to enable the patient to obtain the services of another practitioner. Wonder if you have experience at the federal level, if the practitioner has lost his or her privilege of the DEA license, how the state and federal law are reconciled. In other words, no DEA license means no refills of buprenorphine. So this really goes to the qualifications for a provider who can provide buprenorphine treatment. So they would need to be fully qualified in terms of license, DEA certificate, and that patient would have to be transferred to another qualified provider to receive care. Okay, here's an experience of someone who did provide telemedicine in an emergency. However, you have to get a physician waivered with an online program, verify the CSAT granting a waiver, and then the patient is linked was linked via telemedicine to addiction medicine specialists and psychiatrists to it sounds like make that linkage, and then as soon as they were comfortable, then the the provider would be able to see those patients independently. And in this case, the physician was limited to specialist. So it was and I'm sure that the physician had to be qualified under Data 2000. I wonder if anybody has had any experiences related to the storms. I heard anecdotal stories from Hurricane Sandy that some patients were displaced, but haven't heard anything in terms of the impact of that. And I did inquire at SAMHSA and with the person who manages that area of the state, and they had not received any reports or data. Oh, okay. We have a clarification about the telemedicine. So the telemedicine was really between the physicians linking to the other specialists, and so it sounds like that was an educational and a supervisory kind of consulting role, and the patient was not part of that session. So utilizing telemedicine to really help mentor physicians who are coming into this role, relatively new coming into the role. Well, we have just a few more minutes before we close. I'm impressed with the dialogue that's gone on and the questions that have come in. Take maybe a couple more questions if anybody has any last-minute questions or comments that they want to weigh in on. Well, and then I think we will end now. I want to thank people for their attentiveness, for really engaging in the dialogue here with wonderful questions and sharing your own expertise in terms of your work with office-based treatments. So we will be providing webinars in the future, and we will be having more of those scheduled through the next several months, and we'll be sending that information out to you. In closing, I want to thank everyone for participating. Shortly, the participants will receive an email from the American Academy of Addiction Psychiatry that includes a link to an evaluation survey. Please take a few minutes to access it and provide your feedback on today's sessions. And with that feedback, I'd also ask if you have ideas and topics that you would like to see presented, if you would add those as well. That's really helpful for planning for next year's webinars. The webinar today was recorded and will be posted on the website of the Physicians Clinical Support System, Opioid Therapies in the Near Future. The website is www.pcss-o.org. A calendar of upcoming events and helpful clinical resources are available there as well. So we do hope that you will join us for upcoming PCSSO sessions. And thank you and have a great rest of your day and week.